I request Dr. MARIAN PAULY to present the next talk, Challenges in the Management of Lid Hematomas.
Good afternoon, everyone. Thank AIOS for giving me this opportunity. So, a few challenges in the management of late hematomas, primarily a case-based discussion. So, coming to the evaluation of late hematoma, always we have seen most of the time it's post-traumatic hematoma, but in that case you have to know whether it is accidental trauma or exactly what's the nature of the trauma. You can get a post-op after surgery, then after peribulbar injections, then vascular malformations, then blood dyscrasias, etc. Whatever is the case, you have to evaluate completely. Even though obviously it looks like a lid hematoma, always assess for any optic nerve dysfunction, check the intraocular pressure, ocular motility, and look for lag of ophthalmos. Coming to the investigations, we have to get, if it's a non-traumatic hematoma, you have to get all the coagulation parameters to check and look for any drugs patient is on, and imaging. Management goals primarily to preserve the vision, treat compressive optic neuropathy present, protect the cornea, control IOP, and prevent any occlusions. So medical management, first of all, ice compresses, systemic steroids if it is a big hematoma, oral serratiopeptidase. If IOP is high, you can give acetazolamide and acusuppressants. So coming to the cases. So case one, first one is a 63-year-old female presented with injury with a wooden stick, right eye. So on examination, there is a total lid hematoma with a mechanical ptosis, but you have to always see the globe. There is a proptosis and the vision is only 6/12. And there is RAPD and motility restrictor. So there is an element of compressive optic neuropathy. In this case, we have to rule out globe rupture also. If there is an element compressive neuropathy, always start the treatment. We can admit if there's a hematoma, or can start with some hemostatic agents, that is encapsulate, which is the one which we commonly used in our hospital, and stabilize the patient. You can give a first dose of intravenous steroids just to prevent the visual loss, and then send the patient for imaging to see the extent of the bleed. Coming to the second case, this patient is another 35-year-old patient presented with the injury while cutting tiles. So on examination, on external examination, you can see a small lid hematoma with the subconjunctival hemorrhage. So on close examination, otherwise eye is all right, like vision 6/6, pupil normal, fundus normal, ocular motility full. So on a close examination, you can see there is a small laceration here. So this you cannot treat just like a simple hematoma. You have to get the imaging done. So it showed a portion of the tile and needs exploration, and the tile has been removed. So this case highlights the importance of imaging, and always ask the nature of the injury. Coming to third case, 25 years, presented with the redness and blurring. On examination, vision 6/12 and 6, pupil RAPD. So there is no history of trauma, so you have to rule out other causes. So it was a case of orbital varix with the bleed. So treated with steroids, since had compressive optic neuropathy, intravenous methylprednisolone, oral steroids, vision improved, and we have taken an opinion from interventional radiologist also. Similar is the case with the lymphangioma. So it presents with a bleed either in the subconjunctival space or in the lid. Get the imaging done and diagnose what exactly is the reason. If there is a compressive optic neuropathy, you can do an immediate canthotomy and inferior cantholysis in the OPD itself to preserve the vision. This is pediatric cases. Sometimes lots of diagnostic dilemmas can come. Acute onset proptosis can be due to either hematoma or a neoplasm. So look at this image. He's a 10-year-old boy. You can see a board-shaped lesion in the superior orbit. So radiologist has given a DD as either neoplasm or subperiosteal hematoma. In pediatric cases, you cannot, very difficult to elicit the trauma history. So we have taken the child under written informed consent. First we aspirated and blood came off, so diagnosed as subperiosteal hematoma. But this is again another case, again similar radiological picture with a vague history of trauma, but this turned out to be rhabdomyosarcoma. So this kind of cases you have to manage with a very caution. Then hematomas associated with the fractures, usually it's like benign. Wait for the hematoma to resolve before embark on the fracture floor after reassessment. So coming to the post-operative lid hematoma, this patient who had undergone an uncomplicated ptosis correction presented to us 1 week following surgery. After a sneeze, he developed a small hematoma involving the upper eyelid. You can see this is a initially managed conservatively. So 1 week you can see some changes on the skin, like skin is going for necrosis, and there's an aesthetic element also because the patient had undergone ptosis correction. So we planned for drainage. All the investigations were within normal limit in the preoperative period. Even though we tried aspiration, again fresh blood was coming up. So I have put a pressure bandage and removed after 5 days, but still it started bleeding. So again managed conservatively. Even at 4 weeks this was persisting. So like we were thinking what is happening in this young boy that is 18 years. Repeat cauterization and repeat drainage and extensive cauterization was done under general anesthesia, and extensive hematological evaluation was also done. So in this repeat routine blood examination, we found eosinophils were very high. So we had then the other differentials came in, whether it is leukemia, eosinophilic vasculitis, or any abnormalities with coagulation. So we investigated him further with platelet function testing. So in the platelet function testing, he had low aggregation pattern to ADP and collagen or platelet function testing. So in this case, we had eosinophilia and abnormal aggregation pattern on platelet function testing. So he was diagnosed to have acquired platelet dysfunction with eosinophilia syndrome. So this is eosinophilia is a very common condition we see in our practice, but when we do surgery, you can get this kind of picture. It is usually seen in younger age group and self-resolving condition. The mechanism is not clearly known, but eosinophilic cationic protein, that's the basic protein in the eosinophil primary matrix, described as the platelet aggregation inhibitor. So that is why the bleed comes. Coming to the 8th case, again it's a typical lid hematoma presented following road traffic accident after 1 week. So initially conservative management was not resolving fully, and he was getting some skin changes, so he underwent a clot evacuation under local anesthesia, and he did well. So now again 9-month-old child presented to us with a vague history of trauma because from the parents. But in this case, there is a lid hematoma and subconjunctival hemorrhage. Here also some bruise is there. Now look at the child, there is an element of anemia. So this is a very dangerous situation. Don't go for MRI first. Get the routine blood and peripheral smear. It was a case of acute myeloid leukemia presenting as scleroma. So lid hematomas, myriad of presentations, always assess the etiology and always ask for the history also. Aim is to preserve the vision, explain the possibility for rebleed in some of the cases. Mostly it will improve with conservative management, surgical management only if indicated, and we'll get a gratifying results. Thank you.
Thank you, Marian. This people with liver dysfunction has, when we give peribulbar block, no, you will get
Hematoma, yeah.
hematoma. Liver, other bleeding clotting time, I mean hematological, we always check, but liver we not check.
Yes.
So thank you, doctor. Any other comments? Thank you very much for that.